Adil El-Taya was born in northeast Sudan in 1956, in a railway town built by the British. One of 12, he was bright and became a transplant surgeon. Like so many doctors in the National Health Service, Adil came to Britain, where he practiced for decades, and when coronavirus struck, he volunteered to go back to the front line. But he soon fell ill, and 2 weeks later, he was dead from the virus. He was 64. He was one of the first doctors to die in Britain. In news reports, his picture sits side by side with all the other NHS workers who've lost their lives. And if you look at those faces, one thing stands out clearly. Of the 119 cases of NHS deaths, more than 2/3 are black or an ethnic minority, yet they only make up 20% of the workforce. Figures from NHS England show a disproportionate number of COVID-19 deaths in the country are amongst these groups, and it's not just in the UK. In the United States, on available data, African Americans account for 35% of deaths, yet they make up 13% of the population. So what's going on? This week on The Inquiry, we ask, why are so many ethnic minorities in the UK and US dying from COVID-19?
Part 1. Critical Data.
When I go on Thursday evening at 8 o'clock with my plastic spoon and my saucepan, I bang my drum for the NHS.
This is Professor Kathy Rowan, Director of the Intensive Care National Audit and Research Centre, also known as ICNARC. It conducts research into emergency and critical care. And when she claps, she's thinking of her colleagues in the NHS.
At a very, very difficult and stressful time.
Because of fears early on in the pandemic that intensive care could be overwhelmed, ICNARC decided it would support colleagues there as well as policymakers. They started to collect data of patients confirmed with COVID-19 who were in critical care.
One of the many characteristics that we look at of patients with any disease is obviously things around the age of the patient, the gender of the patient, and also the ethnic category.
And when the first set of figures came back,
I was surprised at the numbers I saw. I can remember looking at the data and thinking, wow. I've never seen such a low proportion of people from a white background and such a higher proportion from other black and minority ethnic groups.
So Kathy Rowan decided to dig deep into the figures to try and understand what was going on. The virus spreads quickly in densely populated cities, and she wanted to take on the argument she thought would arise of,
hold on a minute, the epidemic has started in urban areas. What if this is just a reflection of the urban areas from where the patients are coming, the different minority ethnic group mix of those areas?
So ICNARC made an adjustment. They use residential postcodes to identify wards or areas from the 2011 census, and then look at the black and ethnic minority group mix in those wards.
Which then allows us, if you like, to estimate the proportion of patients we would expect for the population of patients with COVID-19 in critical care, and the distribution that we are seeing.
Using the data from their 24th of April report, based on around 6,000 patients, it showed they'd expect, based on where the white population lived, 77% with COVID-19 to be in critical care. But in fact, it was 66%. And when it came to the ethnic breakdown, the figures were stark.
When you move to patients with an Asian background,
and by Asian, they meant East and South Asian.
We would expect about a population of about 12%, and we saw 15% with an Asian background. And then those with a black background, we found 6.5% we would have expected, and 11% of patients with confirmed COVID-19.
For the black community, that is quite a significant increase, isn't it?
The black population is the one that stands out in that that's sort of getting on for 30 to 40% increase over what we would expect, and probably is the one that sticks out the most.
This data showed that while minorities make up 13% of the UK population, they account for over a third of coronavirus patients admitted to hospital critical care units. It alerted policymakers, along with a stark number of deaths of NHS staff, that the black and ethnic minority population were being disproportionately affected. The government launched a review in Britain to find out why.
It's fantastic that we have these data, and I think they're fairly unique internationally.
And the detail of ICNARC's data is unique. In France, another European country with a diverse population, statistics on ethnicity aren't allowed to be collected. But there are other European countries that have shown large number of cases within their minority populations. In America, a similar pattern is also emerging.
Part 2. Inequalities.
I'm African American. Grew up in a small town in Mississippi, small being about 3,500 people, and in a part of the country where there's so much poverty and really people who are descendants of slaves and have very little resources and access and are still living in that part of the country.
Our second expert witness is Consuelo Wilkins. She's the Vice President for Health Equity at Vanderbilt University Medical Center in Nashville, Tennessee, in the United States.
I myself experienced health inequities. I saw many of my family members who suffered without access to care, who had poor health outcomes. So it's something that I've been interested in for a very long time.
So when COVID-19 hit America, she was worried.
I thought, well, of course, communities who have been historically marginalized and underserved are at risk for being disproportionately impacted. And we have to do something about it.
And has that been borne out by the statistics when you look at the mortality rates of who is dying from the virus?
It has been. However, I'll preface that by saying that our data isn't the best in the United States.
She's right. In the US, data compiled by the Centers for Disease Control and Prevention is incomplete. And some of the categories collating racial and ethnic information, she says, is vague. But on the figures that are available, they tell the same story.
African Americans, Latinos, Native Americans, American Indians are having higher rates of death.
Is it your experience that health inequalities and structural inequalities that existed are actually exacerbating responses now to COVID-19 to those kind of minority groups?
Absolutely. If we look at in many of our urban cities where historically there have been policies that kept communities segregated, many of the resources are not in these communities of color.
She says many minorities live in communities with no food stores or healthcare clinics, and they can't afford not to work, which means lockdown isn't really lockdown for them.
They can't be on lockdown because they have few economic resources, they have higher travel times to their jobs, they're more likely to be in lower wage earning jobs that require them to work during this time, and they don't have paid leave. So lots of other consequences of those decisions that were made many years ago.
In the US and UK, minorities are more likely to live in deprived urban areas and be disadvantaged. And in both countries, many are in frontline work. Bus drivers, refuse collectors, delivery people, as well as healthcare workers. So they're more exposed to the virus. And in the UK and US, they're also more likely to live in multi-generational households. so it's hard to self-isolate. But there's one area which is particular to millions of minority Americans in lower socioeconomic households.
Some of the messaging has been pretty specific to say, don't go to the emergency room, call your doctor first. But that's something that's infeasible if you don't have a doctor, if you don't have insurance, if you don't have a regular healthcare provider.
So when they seek help, it's very late, which means they're more likely to be seriously ill by the time they reach hospital. She argues the high number of people dying isn't surprising, given long-standing structural inequalities that many minorities face in the US as well as Britain. But there could be other reasons, she says, they're being hard hit too.
Part 3. Underlying issues.
I have a very close friend who has been admitted with COVID into hospital, who is also of ethnic Asian background. I have a friend who died recently, 52, of an Asian background.
Dr. Kamlesh Khunti is a professor of primary care diabetes and vascular medicine at Leicester University Hospital, an English city with a thriving South Asian population.
We've got over 100 now people working within the NHS who've died, and about 72% are of black minority ethnic groups. And straight away that hits you in the face that there is something not right here.
He started to get concerned when the first 6 doctors who died were all from an ethnic minority. And as doctors, these were a group whose socioeconomic background was similar to their non-white colleagues. And then he started receiving phone calls saying a lot of young South Asians were coming into hospital. He decided to voice his concerns on social media, asking if other colleagues around the UK and the world were noticing similar patterns.
After we came out with it, within 1 or 2 days, we started hearing the news from the US regarding the increased risk of COVID in African Americans and the increased mortality. And they were having, in some areas, 80% were African Americans, when their background population was only about 40%.
But there must be a commonality between what is happening amongst ethnic minority groups in Britain and in America. So I just want to discuss with you what you think those are, other than socioeconomic.
So we've looked at the data from China and from Italy, and there's a consistent pattern here. There are certain people with certain conditions who are more likely to get severe disease and then die from it. And the conditions that are coming up seem to be cardiovascular disease, diabetes, and hypertension. And we know these conditions are more common in the black minority ethnic health population.
In the UK, he says, diabetes is more prevalent in South Asians and occurs 12 years earlier on average.
So, for example, diabetes is 2 to 4 times more common in South Asians. In the UK, a white European population would get diabetes at 60, while South Asians get it at the age of 48. African Americans or black populations, they're also more at risk of diabetes. Black populations are more at risk of high blood pressure and strokes, and South Asians are more prone to coronary heart disease, such as heart attacks. So there may be other underlying mechanisms that may be putting these people more at risk.
That means that ethnic minority populations in the UK and US are more likely to get very sick if they catch COVID-19, as they're more likely to have these underlying medical conditions known as comorbidities. And you talked about those 3 conditions with regard to comorbidities. Why those conditions? What is it that makes their reaction to COVID so severe?
It may be because there's an inflammatory process that happens when one gets COVID, but in the black minority ethnic health population, there's already a higher inflammatory markers even before getting the COVID. So it may be that's the case. But no one exactly knows, really. These are all speculative ideas.
It's still not understood why such diverse minority groups have these underlying illnesses. It's most likely a combination of lifestyle, environmental and genetic factors. Right now, the UK and America are in the eye of the storm, but other countries may, he thinks, be able to learn from their research into why ethnic minorities are getting a severe form of COVID-19.
Africa and India are the next phases in this horrible disease. And if we can find things that clearly tell us who are the highest risk, then maybe we can target that messaging even more to those populations.
He says there are other underlying issues that may be relevant too. Obesity, which is associated with the three main comorbidities, and some scientists have raised questions of the role of TB immunity and clotting. But are there other biological reasons?
Part 4. Biology.
We spent the last 20 odd years looking at historical influenza pandemics.
Our final expert witness is John Watkins, a professor of epidemiology at Cardiff University and a consultant epidemiologist.
I don't think anybody living today has seen anything quite like we're living through.
He researches how epidemics spread through populations, and in the immediate weeks after the coronavirus emerged.
Many countries are reporting cases, and in that circumstance, it's going to be a pandemic, and so every country on the planet needs to be prepared.
Back in February, he called on the World Health Organization to call the spread of COVID-19 a pandemic. He was surprised by the response from some quarters.
That did, in fact, provoke interest from people who were interested in the role of vitamin D and the immune system.
Vitamin D is necessary for a strong immune system. It comes from food, but most effectively from sunlight. So in northern latitudes in winter, there's less sunlight, so less active vitamin D production. And if your skin is darker, you need to spend longer in the sun.
Hence, causally related to reduced immunity.
And it had been much discussed in his circles with regard to influenza.
Now, what people were actually suggesting was that supplementing people with vitamin D and raising their active vitamin D levels would boost the immune system and therefore protect people from COVID-19 infection. So that's the route people were coming in.
This was all raised with John Watson before the evidence started to show the high numbers of mortality amongst ethnic minority groups.
Ethnic minority backgrounds who are living in northern climates have a predisposition to being vitamin D deficient. And there is a very legitimate question to say, why is it that people from ethnic backgrounds are overrepresented in those with more severe disease and overrepresented in people who die? As to the question of whether vitamin D is related in any way, and pigmented skin will give you a reduced ability in the same sunlight exposure.
It's also the case for African Americans as well, where they too suffer from vitamin D deficiency. There's some evidence to show that low vitamin D is a factor in the acquisition and progression of respiratory conditions, and studies are now taking place to look at those in critical care and who've died and their vitamin D levels. But we know, don't we, that vitamin D is recommended for people from ethnic minorities, but do you think that more needs to be done? For example, in the past, vitamin D was put into chapati flour in Glasgow. Do you think something similar has to be done now?
So actually, food supplementation with vitamin D, particularly in ethnic foods, etc., seems to be a wholly sensible thing to do.
And for the NHS workforce, the British Association of Indian Physicians have written to NHS employers asking for doctors to have their vitamin D levels tested as a precaution. There may be other biological explanations as well, he says.
It could also be part of genetic predisposition, because that is about individual immune response to the viral illness. It's not about the severity of the virus itself. It's about the interaction between the individual and the virus.
The medical name for these normal genetic variations is polymorphisms.
Your immune system and my immune system are unique to you and unique to me.
While he says we're all mixed up genetically, certain polymorphisms occur with varying frequency in different ethnic populations. He says there's always differences in the immune system that results in the lottery of your response to a virus, and genetics could well play a part in the immune response to COVID-19. And while scientists investigate why ethnic minorities are more vulnerable, including their genetics, he says we should be taking precautions now.
Therefore, we probably ought to shield those from the absolute front line because their outcomes might be worse.
It's a step that's already being taken in some NHS trusts. Why are so many ethnic minorities dying in the UK and US? This isn't going to be one of those programmes where there's a clear answer. It's complex, and scientists and policymakers are just beginning to grapple with it. The data has proved crucial and continues to be refined. But what we know with certainty is that disproportionately large numbers of ethnic minorities are ending up in intensive care and dying, not only in the UK, but also in the US. We also know pre-existing structural inequalities and underlying health issues have a role too, and the importance of vitamin D, TB immunity and genetics is being studied. But behind every statistic is a person, a history, a journey. Adil El-Taya had a last wish. The doctor who chose to work on the coronavirus front line in Britain's National Health Service and died in the act of helping sick patients, wanted to be buried in the country of his birth, to return to Sudan.